Our next speaker is well known to us all. He has a deceptively short bio, which is a complete understatement of his contribution to our society over the last, well, it's more than 20 years. Professor Buscombe trained in nuclear medicine in London before working in London and Cambridge, and since 2010 has been an extraordinary professor at the University of Pretoria. Since 2020, he's been working at St Bartholomew's Hospital in London and has a long-term interest in theranostics and has published over 250 peer-reviewed papers and 8 books. Professor Buscombe.
Hi, I was asked to talk about parathyroid imaging and a sort of update. Not that there's much update, but at least we can talk about parathyroid imaging. So I'm actually going to start off because just to celebrate the fact that my hospital has had its 900th birthday this year. We've been on the same site and treating the patients of East London without charge for 900 years. So I think that's quite an achievement. So this is a few pictures that some of you may remember or of note. The first is our stairway up to our great hall. This was painted by a famous British painter called Hogarth for free because they asked an Italian painter, and he said, "You can't have an Italian painter, I'll do it for free." And it's a picture of Jesus healing the paralytic, and there's also the Good Samaritan. On the other side is the central courtyard of my hospital. So this is a nice place you can sit out in the summer. I picked the one sunny day to take that picture. The bottom image is of Dr. Papa Fallow. Now, the reason that that's important, this was the first black African medical student in the UK. He came from the Gold Coast and he went back to what's now Ghana to practice medicine. So again, we've had a long tradition of education and education across the Commonwealth. The picture with the coffee bar, that's nuclear medicine. We have our own espresso bar. I bet none of you got one of them. Yeah. And those of you who are slightly older will recognise that the first nuclear medicine physician at St Bartholomew's was Professor Keith Britton, and many of you who are in training schemes around the world, they were actually all set up by Professor Keith Britton, particularly those in the English-speaking world and Commonwealth. So if you're here, back in the midst of time, it was probably because of Keith Britton and all the work that he did. So I just need to give you some disclosures. None of these are related to parathyroids. So what do we know about the parathyroid? I'm going to talk a bit about the old methods, which are still quite good, to be honest. Subtraction method, washout with MIBI, SPECT and SPECT-CT, and of course, because everybody wants to do it, fancy stuff, PET. So one of the most important things is to go back and try and remember the embryology, because it's all related to the embryology, the problems that we have with trying to identify where a parathyroid adenoma is. So they come from the 3rd and 4th brachial arches, not arteries. And the upper parathyroids bizarrely come from the lower arch. So they've got a longer distance to travel. So they start off in the chest in the embryo, and then they move up into the neck. So normally they sit behind the thyroid. However, they can literally go anywhere between the aorta and the soft palate. So ectopic tissue can be almost anywhere. Now there are 2 cell types. There's the chief cells, big chief, and they make and release the parathyroid hormone. But they're not the most common cells. The most common cells are these ones called oxyphil cells, and nobody knows what they do. Now, we don't diagnose it with imaging. This is diagnosed with a blood test. The patient has a high calcium. They then have a parathormone level. It's elevated. They have an adenoma somewhere. And then there starts how to search to find it. So in the perfect world, we'd have a tracer that has just uptaken the parathyroid adenomas, nowhere else, nothing, all brilliant, it's easy. The only problem is that tracer doesn't exist. So it would be good, and it would be really good if we could find really, really small adenomas, because they're often only about 5 or 6 millimeters. And again, you can see single photon. That might be a problem. So let's have a look at a little difference between the physiology of the 2 cells, because we are in vivo physiologists, aren't we? So the thyroid has the NIS gene, and it has uptake of iodine or patetnetate. It has a low density of mitochondria, and it produces a thyroid hormone based on tyrosine. And it has a high expression of GLUT1. So you can think along the lines of iodine, patetnetate, FDG, labeled tyrosines. The parathyroid has no NIS gene. It has lots and lots of mitochondria, so that's what MIBI likes. Also, the parathyroid hormone is a very complex amino acid peptide, so that likes amino acids, so maybe that'd be a good way to go. And also, we know that these chief cells seem to love choline. Subtraction technique is fairly simple. We image the patient with two tracers. One tracer has uptake in the thyroid and parathyroid, and that would be something like MIBI or possibly tetraphosphamine. And the other tracer is one that just has uptake in the thyroid, such as patetnetate, or if you've got a lot of money or live in Germany, iodine 123. The most important thing, though, is that you need to keep the patient still between the two tracers. So the uptake of these tracers is fairly fast, particularly if you give it intravenously. But it does mean that the patient is often lying down with the neck extended for up to 50 or 60 minutes. And what you get are two sets of images, one which is just the thyroid, one which is the thyroid and parathyroid. And when you electronically subtract them, out pops your parathyroid adenoma, as long as the patient hasn't moved between scans. This parathyroid adenoma is about the size of a golf ball and probably would be diagnosed by just looking at the patient, but it's quite a nice example. So this was a bit of an issue, so people thought, well, if we could get away without having to do the thyroid scan, it reduces radiation dose, and is there another way to do it? And some French people came up, well, in fact, if we just give MIBI is a dynamic agent in the parathyroid and the thyroid, and it washes out of the thyroid because it doesn't have a lot of mitochondria faster than the parathyroid. So if we take an early picture, we get like the thyroid picture, and if we get the late picture, we get the parathyroid picture. And that's the basis of the washout technique that we use today. Now, when you do that second image, some people do it at 1 hour, some at 2 hours. It used to be done at 4 hours, but by then you're pretty well washed out of everything. So most people are doing the later image at 1 to 2 hours. You can do planar, you can do SPECT, and of course now we can do SPECT-CT. So here we have a negative study. This is with early and late images. And you can see that it's sort of washing out from the thyroid. This patient doesn't have a parathyroid adenoma that they could find, so we don't know if it's negative because they don't have one, or it's negative because they couldn't find one. And that's one of the problems. And one of the difficulties is you can see even in the later images, there's a bit of activity in that area. There's activity in surrounding tissues, so a little adenoma would not be found. So the next stage was to use SPECT. Now, this is before we had SPECT-CT. And here, very nicely, this is an early and late one. This one is pretty obvious in the fact that it has very good uptake of MIBI, and you can see it very clearly in both the early and late SPECT. And for about a decade, this is what we did. But of course, once SPECT-CT turned up, we moved over to that because you have the advantage not only saying we've got a parathyroid adenoma, but you can say actually where it is. And that's quite important because the surgical approach for an upper and lower parathyroid adenoma is very different. The surgeon goes in either from the front or the side. And just to give you an idea how quick it is, we tried to film one for one of these documentaries, and by the time the cameraman had got the focus on the neck, the surgeon had gone in, because we got it localized on MIBI, pulled out the parathyroid adenoma, sewn it up, put 2 terry strips across, and I counted it, and it was 13 seconds, and he had a 0.01 mil blood loss. So he had to put it back in again so we could film it, and pretend it took 2 minutes to take it out. So here we have an ectopic one. This is on the anterior mediastinum, which is a common place, and these ones are really difficult to find because the patient will need to have a thoracotomy. Sometimes the images aren't quite so clear, but you can localize it with SPECT-CT. And here, for example, you can see that the parathyroid adenoma is sitting just behind the thyroid in a classical place. And if you look at the first image, which is the coronal image, you can see it's towards the lower end. So that's almost certainly a lower pole parathyroid adenoma. And that's all you need to say, right or left, upper or lower pole, if it's not ectopic. And most studies demonstrate this delivers between an 80 to 90% sensitivity. Now, when does it fail? Two reasons. Sometimes you get fast washout of MIBI, but the main reason is size. If it's below about 8 millimeters, the SPECT CT doesn't really work. So what do? You don't call Ghostbusters, you call PET scanning, because obviously SPECT scanning is more sensitive and we have better resolution. So what could we do? Well, there's no PET version of MIBI. So what the best thing to do is to try and look at that physiology. What can give us a clue the best way forwards? And as I said before, the most important reason why we don't find the parathyroid adenoma is because they're very small. Now, the radiologist said, oh, well, we just keep doing the ultrasound, or we'll invent 4D CT, which is a normal contrast CT with the late image. And that sometimes helps, and sometimes it doesn't help. So two things may help. We know that they have amino acid uptake because they make these long peptides, so we could use amino acid PET. And we know that the chief cells love choline. So started off, when we started this, we started using amino acid, in this case C11-methionine. The data came from Germany in a small group of patients, and they found that they were able to identify parathyroid adenomas as small as 4 millimeters. Now, I was fortunate enough to work in a hospital with its own cyclotron, so we had access to C11. So here we go. So this is a patient, 63-year-old. They've even had a couple of operations. They still can't find the thing. And they did some venous sampling, and they found it's somewhere in the mediastinum. So they did a MIBI scan, and I've only shown the plane here, but it's as negative on SPECT CT as it is on the planar, but there's no point showing you a slice of SPECT CT. So then we went on to do the C11-methionine PET, and here you can see it's very small. So I put a nice red arrow on for you. That doesn't actually exist on the patient, by the way, just me writing it on the slide. And you can do here on the PET and the PET CT that you can see that there is a small parathyroid adenoma which was removed and the patient's biochemistry returned to normal. So we could identify those smaller lesions that weren't really possible to see with MIBI. But the problem with C11-methionine is it contains C11, so you need to have your own cyclotron. So what about an F18 agent? Well, we don't really have any good, well, we have some F18 amino acids. In fact, fluciclovine, which is used in prostate cancer, is one that could potentially be good. But there may be a better agent because, as we said before, is that the chief cells, the ones that don't have the uptake of MIBI because they don't have the mitochondria, but do make the hormone, seem to have an increased uptake of choline. So choline is used in two things. It's used as food for the cell because it burns choline, but it also is used in the cell wall. So the choline uptake is elevated, and this is classically an area in which we can then use nuclear medicine. So F18 choline, and there's a very nice review published by Ferrari, not the one that makes the cars, it's actually an endocrinologist. He published this in 2021. So choline PET. Now, how was this discovered? In fact, it was discovered by accident. In Ljubljana in Slovenia, they were doing some F18 choline imaging for prostate cancer, and they found some uptake in the neck, and then it was found to be a parathyroid adenoma. So they then went ahead and started systematically looking for parathyroid adenomas, and they found that a very high sensitivity and specificity. And this was published in 2014, and other groups in France confirmed this. And later on, there's also a study in Israel, but it's all based on an original case report that came from Slovenia around about 2012. And all of them was showing a very high sensitivity and a good uptake compared to background. So this is, again, from Ferreira's paper. And here you can see a patient that has been imaged with F18 choline in the top image and the MIBI in the bottom image. Now, interesting, the sort of targeted background is actually slightly better with the MIBI. But as you can see, the resolution of the image is better with the choline. Now, the other thing is that obviously this is quite a large parathyroid adenoma, and therefore possibly not the best one to demonstrate that choline is better than MIBI because it was findable by both. In fact, If you look at that whole body MIP image, it's about, again, it's almost golf ball size. And again, but you can get good localization, and there is clear evidence that there may well be some advantage in using PET in finding these smaller lesions between around about 4 and 10 millimeters. So this was, again, in his review, he was just basically showing that there's good uptake, but no good prospective trials. So it's all very much, retrospective single-site trials that are reported, and therefore the evidence level formally remains low. If you want to look at them in great detail, this is a table. He tabulated the results of the best studies. And overall, if you look at the MIBI, which is over on that side, on both screens, you see the sensitivity is in the 80s, whilst with the F18 choline, it tends to be in the low 90s. Then another group from Italy also were using this, and they also compared this with 4D-CT. So these are patients who generally had failed to have MIBI localization. They were referred into the centre in Genoa for further imaging. So they were sort of a selected group with small adenomas. They also looked at, did a meta-analysis as well with their own results, and they managed to pick up at 153 patients with hyperparathyroidism. And they looked at the sensitivity, but again, there's no outcome data. So the grey bar is if you do 4D-CT and the choline PET, and that was 93%. The CT alone was 77%, and the PET alone was 89%, which was not significantly different from adding CT. So their recommendation is that F-choline PET was probably the best agent. So what about the guidelines? Well, we have the 2021 E&M guidelines. There's not yet a full consensus of when to use F-choline PET, or even the activity that we should give, or when we should give it. Some people say that we should image at 5 minutes, some 60 minutes, some look at late imaging, and this is a bit of an issue in terms of the best way to look at it. And you should image from the palate to the diaphragm. But again, there is no real outcome data or prospective trial data. So this is a study that has been sent to me by Professor Petridis, and here is a parathyroid adenoma which is lying right up in the retropharyngeal space. It's easier to see it on the PET image than on the PET CT image. I think I forgot to, yeah, I think I've got the thing. So here it is, there. And the late imaging, all it does really is just clear background. So it is a little clearer at the 60-minute late image, but in fact, the 5-minute image is just as diagnostic. So you pay some money and it takes your choice, really. So because there is always this issue about does it actually work, the French have finally got together and they got this new trial called Apache 2, which they're setting up, which is a phase 3 multi-center randomized controlled trial comparing choline and MIBI. And the idea is to look at outcomes in terms of correction of calcium. And they're planning to enroll 58 patients across France. And they're going to look at surgical outcome data and biochemical outcome data. And what they're trying to demonstrate is whether or not it is cost effective to use choline, which at the moment looks like the best candidate for PET imaging, where MIBI fails. But MIBI is good in 85%, remember, especially with SPECT-CT. So in summary, most patients would be served well with MIBI imaging, particularly with SPECT or SPECT-CT. Failures tend to be due to small lesions, and there, if we could have specialist centres doing PET that we could refer patients to, I think that would be helpful. They're always better than the anatomical imaging, but we still need to provide outcome data proving this works and it's cost efficient so that governments and insurance companies will invest in it. Thank you very much.